Hello, this is Dr. Bernstein with our May 2019 Teleseminar and Dr. Bernstein's uh, Diabetes University. Thanks for listening and watching. We're going to start. Well, before we start, I want to give you a couple of warnings. The main warning is that my answers to questions are generic answers. They're meant to educate the listeners, not necessarily to solve an individual problem. There's no way that I can know the complete medical history of a questioner, and I can't, I don't know his past medical history, present medical history, haven't done a physical exam. I can't really answer a medical question, so I'm guessing. And the guess could be very incorrect, but it will be educational for the bulk of the listeners. Before we start, we have a few special subjects. The first one is a recent article in the New York Times that confirms what I said in my Diabetes University announcement about 9 months ago. I warned everybody about long sleeves on white coats that you find on doctors and hospitals. I have a white coat on with a short sleeve, and here's the article from April 20th, 2019, New York Times. Basically, it finally points out that there have been many studies that show that disease is spread by doctors who wear long sleeves, that the sleeves of their white coats pick up germs and spread them. So if your doctor is wearing a white coat, tell him to take it off. Also, if he has a tie, the ties are not quite as bad as white coat sleeves, but they also spread germs. Here's another article that likewise supports things that I've been saying for a long time. This is from the journal Diabetes in the May issue 2019. And basically, it's warning that altering the microbiota of the gut, the microbiome, can actually increase antibody attacks on beta cells of the pancreas. Now, what does altering the microbiome mean? In this particular experiment, they actually used antibiotics to destroy the microbiome, but you can also alter the microbiome by changing it, by giving probiotics, usually which are limited in number. That is, if you buy a probiotic over the internet or from a health food store or even a pharmacy, it probably has 2 or 3 different bacteria in it. And your own microbiome might have hundreds of different species in it. So if you start loading yourself every day with a probiotic with, let's say, 3 bacteria, they're going to overwhelm your natural microbiome, and you'll be limited to just the 3 that you've been consuming every day. That can make major changes that can cause all kinds of side effects, one of which, according to this article, is to cause diabetes by increasing the attack of the immune system on beta cells. Here's another article that supports things I've been saying for a long time. This relates to fasting, and it's also in the May 2019 issue of the journal Diabetes. In this particular case, it's pointing out that fasting as is frequently advocated by people who pretend they know how to treat diabetes, fasting not only can cause loss of muscle mass, as I've indicated, it can also impair the activation of vitamin D in the body. So fasting-induced transcription factors repress vitamin D bioactivation. So yet another reason not to use fasting as a treatment for diabetes. Here's another article about exercise, and this was a study performed by the Cognitive Neuroscience Society in San Francisco. I think this may have been a report at a meeting, March 23rd through 26, 2019. And what they learned was that intense exercise can rapidly improve the memory. That is, if they have people on an exercise bike getting their heart rate way up, check their memory with tests prior to the exercise, and then give similar tests after the exercise, the memory seems to improve, but only with very strenuous exercise, which is sort of interesting. Okay, now we'll get down to our questions for the month. Does low carb, or this is a patient who claims to be on a low carb, high fat diet, and my regular listeners know that this is something that I do not advocate. I advocate a low carb diet and a normal amount of protein. By normal, I mean what our ancestors would have eaten in the wild. I'm not pushing fats. Anyway, this person asks, does low carb keep type 2 under control? I'm getting very worried. I don't want to go on meds. Well, low carb may or may not be the only treatment that you require. It depends how much in the way of beta cell loss you've suffered already. If you've lost all your beta cells, you're no longer a type 2, you've become a type 1, and you certainly need injected insulin. And then there's a whole spectrum between very mild type 2 diabetes and type 1. And somewhere along the line, people need medication. The American Diabetes Association wisely recommends that the first medication that you try should be metformin. And that happens to be the same one that I recommend as a trial. But why you don't want to take meds, I don't know. You should do whatever it takes to preserve your beta cells. And since high serum glucose is toxic to beta cells, you want to do whatever it is that you need to keep them alive. You want to minimize blood sugar. Not minimize, but normalize blood sugar. I've been a type 1 for 35 years with an A1C of 4.9 thanks to your advice. I'm also taking metformin, which I thought was suppressing gluconeogenesis, that's the manufacture of glucose from protein, possibly from your own muscles. And it seems to be except when I exercise. I thought the metformin would be like a prophylactic against the blood glucose rise when I exercise. What do you think is going on here? Well, first of all, many people who exercise shortly after they arise in the morning, let's say within the first 3 or 4 hours after they wake up, find that their blood sugars go up. And I've said this over and over on my videos. In fact, one of my very earliest patients had to take 2 units of regular insulin by injection every morning if he was going to exercise, just for the exercise. Uh, so that could be due to the dawn phenomenon, and it has nothing to do with the metformin. It has to do with the fact that the liver uh, destroys insulin in the early morning hours. And if you're going to exercise, you're going to need a certain amount of insulin to uh, offset the stress hormones that you make when you exercise. I have some other people who uh, don't engage in maximal exercise. Uh, they they engage in enough exercise to produce stress hormones at other times of the day, but not strenuous enough to utilize the glucose that the stress hormones cause the body to make. So that's another possibility. Exercise can certainly raise blood sugar in certain individuals, depending upon how much exercise they actually do or how intense the exercise is. The less intense, the more likely that your blood sugar might go up. Uh, and I don't think metformin is necessarily going to change this. What do you recommend as a substitute for bran crisps? I'm a type 1 diabetic and have celiac disease. I love your recipes, but the bran crackers have gluten in them. Well, first of all, I no longer recommend the bran crackers. I mentioned them in my book for people who insist on something crunchy at breakfast, and that was an option. Uh, when I recommend a certain amount of carbohydrate during the day, I'm recommending mostly vegetables to replace the nutrients that you should be getting from a small amount of vegetables each day. As it turns out, if someone follows the meal plans we recommended in the book, they're probably getting more vegetables than the average American is getting. Uh, Although the average American may eat potatoes, he can call those vegetables and corn. Uh, I leave those out. Um, However, if you want something crunchy at breakfast instead of the bran crackers, I would recommend the cheese puffs that we describe in the book. The book is Diabetes Solution, and those are very tasty. I find that even kids like the cheese puffs, and each cheese puff has um, one slice of yellow American cheese in it, and that's about an ounce of protein and a gram of carbohydrate. How many carbohydrates should my 10 years old daughter eat at each meal? She weighs 45 kilograms and is not much fat. Well, first of all, uh, the amount of carbohydrate uh, is should be minimalized, just enough to give her some vegetables at each meal. Um, we recommend that it be reduced in proportion to the body weight. For example, we say 6 grams of carbo for breakfast, 12 for lunch, 12 for dinner, for an adult weighing maybe 140 pounds. And if you weigh 70 pounds, it would be half those amounts of carbohydrate. So we would take it in proportion to her weight. But it's not that she needs carbohydrate, it's that she needs the vitamins and minerals that you might find in vegetables. And in my book, Diabetes Solution, we list some low carbohydrate vegetables, probably about 30 or 35 of them that are acceptable. I am breastfeeding. Do you have an option about breastfeeding and taking glucophage? Um, well, there was one study that I found that showed no ill effects, um, but it does, metformin does get into breast milk. So it does get into the infant. And I think you should check with your pediatrician to get his opinion as to what's the latest updates on giving small amounts of metformin to infants in breast milk. I love peanut butter and jelly sandwiches. Do you have any substitutions for these? I make my own peanut butter with processing peanuts and use grape jelly made with sugar-free pectin and uh, bush xylitol. Well, uh, first of all, the sandwiches probably are being made with some kind of bread, and we don't. I don't recommend bread. I don't recommend peanuts, and I don't recommend grapes. So I cannot think of a substitute for peanut butter and jelly sandwiches. Um, you might try some cheese puffs with smoked salmon and cream cheese on them, um, or some cheese puffs with pastrami and mustard on them. How and in what ways, if any, can women's hormone pills affect blood sugar? Please indicate if you have any knowledge whether birth control pills or hormone replacement therapy can cause diabetes. Um, I would say that you consult with a reproductive endocrinologist and you give it a trial where you look at your blood sugars for perhaps 3 months and see whether they've gone up with the pills. Now, I just got a report from a patient of mine. We had to start her on birth control pills because the week before each period, she would get very erratic, unpredictable blood sugars. And the pill, we've just started them a few weeks ago. And what we found was she requires more insulin, but her blood sugars are more predictable and more stable. So we get more predictability with the birth control pills. It's trial and error. How do you treat LADA diabetes, that's latent autoimmune diabetes of adults, when the patient is continuing to lose weight? A1C is 5.5, insulin levels are low. Patient is 67 years old, bone-thin woman. There is limited information in your book about this type of diabetes. Well, the same guidelines that we would use for any form of diabetes or for, would be applicable here. And that would be protein plus insulin. Insulin helps build muscle, and protein supplies the amino acids for the muscle. So a combination of insulin and protein is the most likely thing that I could think of. How does one combat the effects that cold weather has on blood sugar readings? Well, you could dress warmly. That's one option. You could turn up the heat. You could also, if you're taking insulin, you could increase the insulin doses. I find that for me, I require more insulin in the winter time, and I do it by trial and error. When I see that blood sugars are going up when I'm not eating, such as overnight, I increase my basal insulin dose at bedtime. And if I have to do it at bedtime, I know that I'm probably going to have to do it when I wake up in the morning. So I'll give both of my basal insulin doses increases, slight increases, when the weather changes. But I have to beware that if we get a warm day in the middle of winter, I might be low, my blood sugars might be too low all day long. How to get vitamin C using a low-carb diet? Well, we have a list of about 35 vegetables in my book that are low in carbohydrate, and you now can look on the internet for the vitamin ingredients of these vegetables, and you see which ones are high in vitamin C. Now, as uh, a last resort, uh, if you don't want to be bothered looking on the internet, you could possibly, if you're an adult, take a quarter of 250 milligram vitamin C tablet once a day. So a quarter of 250 would be about 62 milligrams of vitamin C each day. I don't recommend high doses. We know that there are adverse effects to high doses of vitamin C. How to maintain a normal blood sugar while doing high intensity interval training. Well, first of all, in my experience, interval training is not as high intensity as people think. I watch the people at my gym who perform interval training running from one machine to another, and they don't get anywhere near the kind of cardiovascular exercise that I get when I go on an elliptical machine and get my heart rate above my theoretical maximum. Uh, so interval training is, in certain respects, phony. It's very hard to get your heart rate up, really substantially. But what you can do is have a continuous glucose monitor, as I do. You can take frequent blood sugar readings if you do or if you don't have a continuous glucose monitor. And you could use liquid glucose to bring your blood sugar up if it gets too low. Now, I wear a continuous glucose monitor when I exercise. I when I do a cardiovascular exercise, which is totally separate from my weightlifting, bodybuilding exercises, I'll get my blood sugar up a little bit. I'll get it up to 90 before I start, where my target is usually about 83. And it takes me about, I guess, a half an hour, maybe 40 minutes of going up to my maximum heart rate several times to get what I consider an adequate workout. And over that period of time, my blood sugar might drop considerably. So in addition to having the continuous glucose monitor on, I will stop after I reach my maximum twice. I'll get another blood sugar and correct it before I go after my theoretical maximum for the third time. And all the while, I'm using liquid glucose as the vehicle for raising my blood sugar. Now, if you're doing interval training, you're going to have to take a break to check your blood sugar. And it depends how long you're doing the training. If you're doing it for only 20 minutes, you might not have a tremendous drop. But if you're doing it for a period of an hour or more, you may have to stop and check your blood sugar several times. The continuous glucose monitor, remember, is usually a half an hour behind your real blood sugar. I'm 33 years old with type 1 diabetes, so this person is a survivor. I use Lantus and NovoRapid. Problem is my blood sugar fluctuates with some food and with some with same units. I see. With same food and same units of insulin. If I take 10 units of Novolog in morning, my blood sugar is normal, but after 4 to 5 days, I get hypos with the same units, and after 3 days, uh, um, uh, may be normal again. I've changed the insulin site also in the afternoon. Sometimes I take 8 units, sometimes 14 units. I get hypos daily. Please advise to make units I take consistent. Well, first of all, you're taking large doses of insulin, of rapid-acting insulin. And I advocate in my book that you never inject more than 7 units in a site at the same time. So you're getting unpredictable absorption by injecting large amounts of insulin. Secondly, you're probably eating a lot of carbohydrate, which gives further unpredictability to your blood sugars. And when you say the same food, you're probably talking about the same high carbohydrate foods. And let's say that you have a meal with 100 grams of carbohydrate and you think it's the same, but it's off by a minute 10% from one day to the next. 10% of 100 is 10 grams. 1 gram of carbohydrate will raise my blood sugar by 80. So that 10% difference can mean 80 on my blood sugar. If you're obese or overweight, it might raise yours less, but still it can make a big difference. So I would first of all advise you to read my book. Another thing to point out is gastroparesis. If you've had diabetes for 33 years, the chances are that your blood sugars have been elevated for a large percentage of that time, and that you have autonomic neuropathy, which includes gastroparesis. Gastroparesis leads to unpredictable stomach emptying and unpredictable blood sugars after meals. So you can read the chapter on gastroparesis in my book, Diabetes Solution. I'm 52 years old, type 2 for 15 years. I just finished physical exam at Mayo Clinic. While the exam was thorough, they didn't do calcium score test. Their main argument was that the outcome of the test would not affect treatment recommendation. I currently take metformin and statins. Should I insist? And if yes, what counter argument can I use? Well, first of all, one reason to do a calcium score test is to find out whether you're a candidate for a statin. Remember that although statins were a while back prescribed for everybody, every adult in the world, according to the guidelines, we now know that they're virtually ineffective when used for primary prevention. Primary prevention means preventing heart attacks in someone who has no risk factors. For secondary prevention, they are of some value, and for some people might be of considerable value because they lower inflammation. Now, if you're already taking a statin, you can't use, you don't have an excuse for getting a calcium score. So the question is, why do you want one? Now, I use the calcium score for another reason. I use it before I prescribe an intense exercise regimen. By intense, I mean a high heart rate cardiovascular regimen. Uh, I don't want to give somebody a heart attack by having them exercise near their theoretical maximum heart rate. So uh, we get a calcium score, and any diabetic over the age of 30 I'll order a calcium score before I will prescribe cardiovascular exercise. In fact, I'll tell them to avoid it uh, if they've not been doing it on their own until we get a calcium score. Um, so I don't know why you should be bothering them to do this under your situation. I'm a 58-year-old type 1 diabetic since 1982. I was being treated for depression and hypertension. 8 months ago, I started your diet. I noticed weight loss, significant energy gains, and motivation, no longer on antidepressants nor hypertensive meds. Both of these symptoms are gone. My question, my energy levels and motivation levels have decreased recently, past 3 weeks, and no changes in my diet. Possible causes. Well, the first thing that I can think of is what happens to so many people who bring down their blood sugar levels. If they're taking blood sugar medications, go on a low carbohydrate diet, and don't lower their medications, they might get hypoglycemia, or even more commonly, they might get relative hypoglycemia. That is, their blood sugars are lower relative to what they were. And it's very possible to get the symptoms of hypoglycemia, which include low energy levels, etc., um, uh, just from having a lower blood sugar than you had before. You adapted to those high blood sugars. Your physiology adapted to it, and that's the reason for many people, lower blood sugars gradually, but it varies with the individual. I just spoke to the mother of a child where we're uh, shooting for blood sugars of 120. However, the same day, today, I spoke to the mother of another child where we started at 120 and now we're shooting for 75 because we gradually got his blood sugars down um, without getting hypoglycemic symptoms. And he's now spending the whole day in the 70s. So one possibility is relative hypoglycemia. So certainly you should check blood sugars and see what they're running. And if you have records of your prior blood sugars, it would be interesting to compare them. A continuous glucose monitor would certainly be warranted since you're a type 1 diabetic. Another possibility is that you check your thyroid level, your free T3, because many diabetics have other autoimmune disorders like low thyroid, and the low thyroid can come on any time during your life. My hypothyroidism came on about 5 years after I developed diabetes. For another person, it might be 25 years after they develop diabetes, or they might become hypothyroid prior to the development of diabetes. I am a male LADA type 1.5 diabetic. Now, I object to the terms type 1.5, and I think LADA is overused. It seems like doctors like to use the term LADA for any person who becomes diabetic after the age of 40, who has blood sugars that are either very easy to control or very hard to control. Anyway, and I certainly don't like type 1.5. Anyway, we'll proceed. My A1C is 7.2, so that's pretty high. Diagnosed 3 years ago at age 44. I went on a pump and insulin shortly after, but I've had terrible side effects such as shortness of breath, facial and throat swelling, visual disturbances, and migraines and body aches since starting on insulin. I've tried all of the short and long-acting insulins, but I'm having worse and worse reactions. It is very scary, and my doctors don't know what to do. Allergists, endos, cardiologists, ENTs, etc. How do I get my immune system to calm down? Well, first of all, you might try switching to human insulin, which is rarely used nowadays. The only human insulins on the market today are NPH and regular. We use regular before meals. NPH is an intermediate acting insulin that really has no role today, but we do use it for children, or especially infants, because it can be diluted, and many of the synthetic insulins cannot be diluted. None of the synthetic long-acting insulins can be diluted. So for these infants, we might give them NPH insulin 4 to 6 times a day. And for an adult, you might need 4 to 6 shots of NPH insulin plus mealtime regular insulin. And you'll be using human insulins and humans are less likely to be allergic to human insulins. So that's one option. Another option is to desensitize you to insulin. And that usually requires diluting the insulin, which can pose a problem if the insulins you're being given are not dilutable. Humalog is dilutable, Novolog is dilutable, regular is dilutable, NPH is dilutable, but most of the other insulins, including all of the long-acting insulins, are not dilutable. To desensitize a person, you actually dilute the insulin and give an intradermal injection of a highly diluted form, maybe diluted to 1 part in 1,000. And you gradually, over time, over the course of a day, every half hour, decrease the dilution tenfold. So you might go 1 shot 1,000 to 1, then the next shot might be 100 to 1, the next shot 10 to 1, etc. The insulin manufacturers may know the protocols for desensitizing to their particular insulins. I did desensitizations many years ago, but in those days we had all of our insulins were dilutable, and they were all human insulins. So you now have problems. An allergist might know how to dilute you, how to desensitize you with these special shots. Husband has type 1.5, again, type 1.5. Also has hemochromatosis. Hemochromatosis is an inherited disorder where the body stores iron, does not unload dietary iron. And this can be very toxic. It can injure the liver, it can injure the pancreas, can cause diabetes, and can even injure the brain and cause psychosis. So it's a very serious disorder, and the usual treatment is to have a hematologist draw blood from you every a month or two. Also, some people just don't donate blood, but it should be supervised by a hematologist. Other than phlebotomy, which is donating blood, is there anything else we can do? And there isn't. That's the treatment for hemochromatosis. And it's very important that you take it very seriously. Also, your first degree relatives, your children, your siblings should be tested for the same disease, because we frequently find it running in families. I once had a patient with hemochromatosis who was acting pretty crazy. It had gotten to his brain. And he was complaining that his daughter was psychotic. And I told him that he had to have her tested immediately. And of course, they found out that she had hemochromatosis also. I'm a type 2 diabetic. Can one combine the keto diet and the Dr. Bernstein diet together? What supplements would you recommend? Can the Dr. Bernstein diet and health clinic recommended B6, B12, APOC, etc., and a whole list of vitamins? Apparently, there's another Dr. Bernstein who has a Dr. Bernstein diet and health clinic. It ain't me. And he's selling pills. And I would say that I looked it up on the internet. It appears to be a franchise business. And I would beware of any doctor who's trying to sell cures, pills, etc. My videos are free. I don't sell them. And I get a small royalty on my books that I have to split with literary agents, etc. So I don't make a profit based upon what you do with your own treatment. My morning blood sugars rise quickly. I would like to switch to a longer lasting insulin such as Tresiba, but don't know how much to take. I currently take Levemir twice daily, 6 units morning and night. Well, again, it tells you in my book. And what I usually recommend, which may or may not be applicable to you, and you could discuss this with your doctor, I usually suspect that the dosage would be the same as with the Levemir, but I initially take a safety factor, and I lower the dose by 20% or so initially. So the Tresiba, I might take 2 units less twice daily, and if I find my blood sugars are going too high, I'd raise the dose. You may end up requiring a unit more twice daily. We don't know. It's all trial and error. So you have to experiment. But I usually experiment on the low side because I'd rather a patient be temporarily too high than temporarily too low. I'm about 100 pounds overweight. I have reduced daily carbs to under 30 quality vegetable carbs, which, by the way, is what I try to recommend. I don't recommend that you take carbs in your diet to have fun, to get the fun foods. Rather, I do suggest that to get vegetables. I've scoured your book for instructions on how to lower my insulin and cannot find instructions. Please point me to the location in the book where I might find some instructions on how to reduce insulin so that I might lose weight. Well, if you want to lose weight, I'd suggest that you discuss with your doctor a number of possibilities. One possibility is to take metformin, which might lower your insulin requirements. And remember, one way to lose weight is to lower insulin doses, but you don't want to lower doses and raise your blood sugar. So metformin may help. Avandia is another drug that helps to lower insulin requirements. So that's a possibility. And of course, you can take metformin and Avandia together. There are potential side effects of both of these that don't affect many people, but one has to be wary of them. Then there's exercise. If you're a candidate for exercise, that could be extremely helpful. I have a number of people who are overweight where we are able, or where I'm already giving them metformin, reducing their doses of insulin, and you give them frequent exercise, sometimes daily exercise, using different groups, muscle groups each day. And the combination seems to work very nicely. There's, with a big question mark, eating less protein to be able to lower the insulin. But if you're going to exercise, you're going to need more protein. So I don't go for that option, really. I try to increase insulin sensitivity, increase in exercise, etc. I'm a type 2 diabetic on medication, Jardiance, gliclazide, and metformin. I'm looking to eliminate the gliclazide and stay only on the Jardiance and metformin to keep blood sugar under control using a low-carb diet. Do you think that Jardiance and gliclazide are bad medications for type 2 diabetes? Okay, first of all, I suggest you read my book, Diabetes Solution. And the metformin usually is a very benign medication. There are certain cautionary things about it, and we do discuss them in my videos. The gliclazide, I certainly recommend against. It's the sulfonylurea, and the sulfonylureas have been shown to have adverse cardiac effects. In addition, there's a fairly high incidence of hypoglycemia, and since their effects are less predictable than the effects of injected insulin, I just don't like the sulfonylureas. The metformin is worthwhile. Diet is low carbohydrate diet is certainly mandatory and will make a difference. And the Jardiance is something, it's an SGLT2 inhibitor, and this class of drugs have been shown to have a potent effect upon blood sugar, reducing blood sugar. And there are some studies that claim to show cardiac benefits, but I have seen a number of cases of dehydration with this class of drugs, and I don't like to use it. I have one patient who has better blood sugar control than he ever had prior to taking it, and he insists on taking it, and I go along with it. But you have to drink a lot of fluid. There are potential adverse effects if you don't drink a lot of fluid, and it just worries me. I've seen high hematocrit. I've seen abnormal electrolytes in patients who use this. I had 2 stents in heart valves 2 months ago. Can I adopt your diet to get rid of insulin and diabetic tablets for normalizing sugar levels? Well, the goal should be to normalize blood sugar, not to get rid of medications. What the book and my diet alone may not be enough. A low carbohydrate diet, in my experience, is the biggest thing we could do. Let's say a patient has an A1C of 13. You might get the A1C from 13 down to 9 with just diet. But then to get it from 9 down to 4.9, you might need medications. So you do whatever it takes to get the blood sugars down in a safe fashion. I suggest you read the book for the guidelines. I've had type 1 diabetes for nearly 50 years. So this person is really a survivor against very strong odds. By the way, next year I will have had type 1 for 75 years. And following your regimen for about 2 years, my problem is that our insulin seems to outlast protein meals. What do you think about using Novolog right after a protein meal instead of R? I think just the opposite. I think that you take the R. If you're going to take anything after a meal, you take the R because it lasts longer. But you can first you can experiment. You might take it immediately before a meal. I take it about 40 minutes before a meal, but people with gastroparesis may take it immediately before. Some take it in the middle of the meal, some take it an hour after a meal. So if you've had diabetes for a long time, you might have gastroparesis. Then you have a whole new problem. So the one thing I do not recommend is a rapid-acting insulin like Novolog, a super rapid insulin, to cover meals if you have gastroparesis. You want a slow-acting meal, and you might have to take it after the meal. Another trick we use for gastroparesis is to mix a little bit of NPH in with the regular to slow down the regular. But we have a whole chapter on gastroparesis in my book, Diabetes Solution. I've looked over your list of prohibited foods as it is overwhelming. Is there a list of what can be eaten? I suggest you read my book, Diabetes Solution, and it tells you what can be eaten. In fact, we have a list of about 30 or 35 vegetables, plus many protein foods, eggs, fish, fowl, meat, cheese. I just picked up Yoplait plain yogurt in the store. The label states that it's made with ultra-filtered milk. The entire container of 150 grams has only 2 grams of carbs. I find it unusual. Well, I looked it up too, and it said that it had 17 grams of protein in a 3-ounce serving, which is pretty amazing. And indeed, only 2 grams of carbs. So I think that this is stuff that's worth trying and experimenting with if you're on a low carbohydrate diet. How do you recommend adjusting Tresiba dosage in the night prior to a day of intense physical activity? Well, there's a question, first of all, as to whether you should change the Tresiba dose the night before a day of intense activity. It all depends. I have 2 days a week I go to the gym. I don't change my Tresiba doses the night before. The Tresiba lasts a long time, and some of it overhangs yet another day. What I do is I'll consume glucose, liquid glucose, while I'm working out. And I'll take small amounts and try to keep my blood sugar locked at about 83 to 90 while I'm working out. Not always 100% successful, but usually pretty good. So on the other hand, if you're going to be running a marathon on one day, you might want to lower the Tresiba dose for that day. And there the trick would be trial and error. You, while you're practicing for the marathon, you lower your doses until you get to a point where your blood sugar is relatively steady during the marathon. But even then, it's hard to be predictable if you're a type 1 diabetic, but you do your best. It's trial and error. You experiment. And of course, different marathons are going to be different. I was looking at your 2014 session where you talked about using the Polar Plus meter to monitor your heart for the cardio part of exercise. What do you think of the wrist heart rate monitors? Or rather, is the one that fits over the chest more accurate in your experience? Yes, I prefer the one that goes over the chest. Your diet has helped me immensely. However, I believe the bran crackers are causing a problem. I love them, but with trial and removal, they seem to be the cause of infrequent, large, painful bowel movements. Can this mean something else? All I need is to add more fiber. Otherwise, they're so helpful. I don't advocate eating a lot of fiber. The reason for selecting vegetables on my list that are high in fiber is because they're slower to digest. It's a source of less rapid acting carbohydrate. This business of pushing a lot of fiber on people, I think, is now antiquated. There were many years ago, it was believed that you could reduce colon cancer by eating a lot of fiber because you would dilute the stool with the fiber, and it was the stool that was causing the colon cancer. Turned out that when clinical trials were actually done, the colon cancer increased in the people who are on the higher fiber diet. So we don't need to push fiber to stop colon cancer. It ain't going to work. If my blood sugar is below 70 and I give myself insulin for a meal I'm about to eat, my lips go numb. Is that normal? If your lips go numb, could well be that you have a high blood sugar. I'm sorry, low blood sugar. So you should be checking your blood sugar. The next time your lips go numb, check your blood sugar. You should read my book so that your blood sugars are kept normal around the clock. It's not a good idea to start a meal with a blood sugar below 70. One of the big mistakes that my new patients make is not correcting a low blood sugar before a meal because they figure their blood sugar is going to go up after the meal. But if they're following my regimen, their blood sugars should not go up after the meal. They should remain the same, and therefore they should correct the blood sugar whenever it's low. So something is not being done right here. I suggest that when your lips go numb, you check your blood sugar. I also suggest you read my book, Diabetes Solution. I'm 42 years old, type 1, another survivor, diagnosed in the year 2000 at the age of 25. My last A1C was 10.2. So that's a blood sugar of around 300 milligrams per deciliter. My wife came across your book recently, and I'm trying to adopt to your teaching. Any suggestions are greatly appreciated. Well, the one thing I worry about is that you've had very poorly controlled diabetes for 19 years. It's almost a certainty that you have gastroparesis, and I therefore suggest that you read the chapter in the book about gastroparesis. I use very little insulin, 10 units of Tresiba, and typically 1 to 4 units of Fias per meal. Needless to say, I throw out a lot of insulin each month because it expires. Is that true, or can I still use the same cartridge of insulin after a month of use? If so, how much longer? Well, first of all, there are 300 units in a cartridge of Tresiba. And if you're taking 10 units a day, it's actually more than 10 units because you need 2 units to fill the needle. And even if you're reusing the needles, probably every 3 days you're squirting away 2 units to fill the needle because you've changed needles. So the 300 units are going to last you 30 days. If you take out the extra 2 units every few days, you're probably going to last only about 25 days. So why are you throwing out any insulin? You're using up a cartridge in less than a month. Now, furthermore, if you were taking less insulin and it took 2 months, that Tresiba is still working. I would keep the Tresiba pen in a refrigerator, and it certainly will last you at least 2 months after you've started using it. Well, that's it for our May 2019 teleseminar. Thanks for watching and listening. Our next teleseminar is going to be on Wednesday, June 25th. Have a good month. Enjoy your summer.